So, hello dear friends. Today I will be talking about organophosphate poisoning, and this organophosphate poisoning is a very important short answer question in pharmacology, and even it is also asked in sometimes biochemistry, because this organophosphate molecules and enzyme actions uh, related to the biochemistry, how I will be showing that too. And by giving the clinical features, you will be asked the clinical cases and its management treatment also in the clinical questions, practical exams, and the very important MCQ and vivas of these organophosphates related are the what is the antidote of this organophosphate poisoning. So all things I will be including here, and please remember this while talking about this organophosphate poisoning, this is basically the cholinergic drugs. These organophosphates are the cholinergic drugs. I have detailed explained. I have explained in detail in the cholinergic drugs classification and cholinergic transmission, like general effects of on topic general effects of the cholinergic drugs, by taking the example of the acetylcholine as a prototype drug. So I request you all to go through that, so that you will be knowing these about these drugs in more detail. And so this organophosphate is being a cholinergic drugs. So cholinergic drugs are the mainly classified natural natural cholinergic drugs, like natural alkaloids and related drugs. And then there are the category known as the anticholinesterase, the drugs that blocks the anticholinesterase enzyme. That enzyme is required for the breakdown of the acetylcholine and hence its action. So, so while talking about the OP poisoning, this will be the common for the clinical features, management, except a few point I will mention there, will be the same for the all um, anticholinesterase poisoning. Like anticholinesterase include reversible and irreversible. Reversible, there are carbamates and non-carbamates. In carbamates there are pyridostigmine, ribostigmine, neostigmine, physostigmine. And then in non-carbamates, reversible non-carbamates, donepezil, tacrine, hydrophonium, and galantamine. Then there is irreversible, something called irreversible anticholinesterase, that include again carbamates, carbamates, which consist of the carbaryl and propoxyl, and then there will be the organophosphates, and that organophosphates will include like diflux diisopropyl fluorophosphate, diazinon, parathione, malathione, ecothiopate. There are many drugs, and there are some nerve gases also in the organophosphates, like uh, tabun, sarin, so on. So to know these, please go through the cholinergic drugs classification. Now let us start this organophosphate poisoning. Organophosphates, like it has the basically structure like, um, if it is carbamate, it has the structure uh, like R1 and R2. This is the carbamates, and there will be the organophosphates. It is the um, derivative of phosphoric acid, and this is the derivative of the carbamic acid. So and there will be R1 and R2. These R group are the hydrocarbons. So this is the basic structure of the organophosphates. Organophosphates. So let's see what these will be doing. So at first you should mention the agent that is causing this OP poisoning. I already mentioned the name of the drug, so mention that. Then we have to mention the effects of this poisoning or the clinical features. So what will they be? What will be the that like effects of OP poisoning. Effects of OP poisoning. These organophosphate molecules, since among them some are the insecticides and some are the homicidal or uh, homicidal agents that are frequently used, and the poisoning may occur due to either due to accidental exposure by unknowingly, or uh, some person may attempt suicide by taking these type of the drugs. So in that case this poisoning may occur. So effect of the organophosphate poisoning. What will happen? These drugs, um, like how this poisoning may occur, either if accidentally ingestion by the mouth, or may exposed may get sprinkled on the skin or on the eye. So these are the major route of the poisoning. Then what will happen? At first muscarinic muscarinic effects muscarinic effects immediately occur on the site of exposure, on the site of exposure, that is, it might be the GIT, gastrointestinal tract site, then it either can be the skin or eye. These are the prone site where the exposure of these drugs can occur. So what will happen? Muscarinic effects immediately occur at the site of exposure, followed by complex systemic effects that can be either due to effects due to muscarinic effect, might be mediated by the muscarinic receptor, muscarinic, nicotinic and central actions of these drugs. Central actions. So to know the effect of these drugs, if you know the physiology, if you know the ANS physiology, it is not big deal for understanding the side effects of these drugs, because basically these drugs, uh, what are doing, these drugs are potentiating the action of the prolonging and potentiating the action of the acetylcholine by preventing its breakdown, since it is since it binds to the acetylcholine esterase enzyme that is required for the breakdown of the acetylcholine, and hence its actions. Then the actions will be of the same as like the parasympathetic effects mediated by the acetylcholine. I will briefly here mention like neurotransmitter in the sympathetic and parasympathetic system. Let us suppose this is the CNS and this is the periphery. Then what happens is that for the if there this is the parasympathetic nuclei in the CNS, then it have the ganglion. At the ganglia, the neurotransmitter will be acetylcholine. Let's suppose this is parasympathetic nervous system fiber, and this autonomic fiber is the bineuron fiber. You also know it, and this will be the first preganglionic fiber, and this is the postganglionic fiber. Then, in case of the sympathetic fiber, what happens is that here also will be the ganglia, and there will be the effector organs, and the skeletal system, musculoskeletal system, the somatic nerve is the unineuron system, and here also the neurotransmitter at neuromuscular junctions will be the acetylcholine. In the sympathetic nervous system, major neurotransmitter is the noradrenaline and also adrenaline from the adrenal medulla. Then and here in parasympathetic nervous system, the neurotransmitter will be the acetylcholine, and this sympathetic nervous system also include two fibers innervating the sweat gland and erector pili muscle. There will be the neurotransmitter acetylcholine instead of this noradrenaline. Means what I am trying to show here is that there is the what these drugs are doing. These drugs are preventing the breakdown of the acetylcholine, and these acetylcholine wherever are present will show its action. Since so the action will be at the also in the somatic nerve, neuromuscular skeletal muscle junction due to increased acetylcholine there too, and there will be the acetylcholine action on the ganglia also, and the whole parasympathetic fibers innervating the tissues. So these will be the actions there. So if you know the physiology of the acetylcholine, how they act, you can mention the adverse effect of this organophosphate poisoning. So let's move forward. And to know this, I also recommend please go through the cholinergic transmission, like general effects of the cholinergic drugs. There I have mentioned the effect of this acetylcholine. So now, and this drug will exaggerate the parasympathetic functions in the various organ system. So let's go to through the organ system. Like first, we will seeing the effect at on the eye. What is happening there? Eye due to excess acetylcholine. So eye, if you know the parasympathetic nervous system ANS, what it will do, it will first it will cause the irritation due to its chemical nature, irritation, then there will be lacrimation, due to irritation, and also due to it act on gland and increases secretion. So lacrimation will also be there besides other glands secretion, irritation, lacrimation. Then there will be the meiosis. Meiosis I have mentioned, this meiosis is the constriction of the pupil. How occurs? Please go through the cholinergic drugs uh, ANS physiology. Meiosis means simply uh, constriction of the pupil. Constriction of all parasympathetic actions are exaggerated in this case. Constriction of pupil, then due to all these effect there will be the blurring of the vision, vision. This is the effect on the eye. And then move on to the like glands I mentioned earlier. Glands, what will be the action there? In glands, hypersalivation, salivary gland stimulates salivary gland, and there will be the hypersalivation and stimulates sweat gland, there will be the sweating. Dear friend, sweating, this is the effect of the sympathetic nervous system, you know. Since sweat glands are innervated by the sympathetic nervous system, but why sweating is happening here, occurring here? Because I already previously mentioned that these sweat glands are innervated by sympathetic nervous, but their neurotransmitter is the acetylcholine, and here these drugs are doing the preserving the acetylcholine and prolonging its action. So acetylcholine mediated sweating will be there in spite of supplied by the sympathetic nervous system. Remember this sweating. Then another effect will be let us suppose in the gastrointestinal tract, GIT and urinary bladder. What will happen there? GIT, like I mentioned, oral manifestation, this salivation will occur, and other muscarinic effects at the site of exposure will also occur. Then increased GI, gastrointestinal secretion and motility. Then it will also cause colic due to increased GI activity, colic and involuntary defecation and urination. You know, these all are the parasympathetic effect. Defecation, for urination and defecation, parasympathetic nervous system facilitate this urination and defecation, and there is the excess parasympathetic, exaggerated parasympathetic action in this case. So this urination and defecation will occur involuntarily, will not be in our control. This is the effect on the GI and urinary bladder. Other effects, mention effect on the and potent effect will be on the respiratory system, and this is the crucial. If respiratory system gets failed, death may ensue. Respiratory effects on respiratory systems. What will happen there? Like increased tracheobronchial secretion, increased tracheobronchial secretion, tracheobronchial secretions, increased tracheobronchial secretions, bronchospasm, bronchospasm, bronchospasm. Then there will be difficulty in breathing, like breathlessness, breathlessness, and respiratory paralysis. Respiratory paralysis, both central, both peripheral and central, both peripheral and central, both peripheral and central. There will be the respiratory paralysis due to the exaggerated action of this acetylcholine. Now, there will be the effect on the cardiovascular system also, effect on cardiovascular system. What will happen? So, if you know the parasympathetic effect on the CVS, you can mention here, like yes, fall in blood pressure, fall in blood pressure, fall in blood pressure, that is hypotension. Why hypotension occur? Hypotension, because this parasympathetic effect, like acetylcholine, what will do? It will act on the endothelium of the blood vessels, and endothelium, there will be releasing, there will be the releasing of the EDRF, endothelium dependent relaxing factor, like nitric oxide, and that nitric oxide will be causing the vasodilatation. Fall in blood pressure, hypotension, then bradycardia or tachycardia. Now here again confusion will arise. Tachycardia, these are doing the parasympathetic effect, so obviously it will cause the bradycardia. But why tachycardia? I mentioned earlier that if the acetylcholine stimulate the ganglia, parasympathetic ganglia, then uh, postganglionic sympathetic fiber will release the adrenaline, noradrenaline, and that will cause the opposite effect to the parasympathetic nervous system, and that what will they do? They will increase the heart rate and even blood pressure. So mixed action will be there, or due to failing this excessive bradycardia, there may be the reflex tachycardia too. So remember, that can happen too. Tachycardia and even vascular collapse may occur. Vascular collapse. Why? Why blood vessels will collapse? Due to the massive release of the nitric oxide, due to the exaggerated action of the acetylcholine, this will cause the massive vasodilatation and vascular collapse may occur. This is the effect on the cardiovascular system. Then the effect will be on the like muscles. muscles like skeletal muscles are supplied by the somatic nerve, and the neurotransmitter there also is the acetylcholine, and here is the increase the condition of the acetylcholine. So that will cause that released acetylcholine is not being degraded by the acetylcholine esterase, because these agents are preventing the acetylcholine esterases. So there will be the repeated firing of the muscles, and that lead to the repeated firing of the muscle will lead to the mus muscular fasciculation, muscular fasciculations, muscular fasciculations and muscular fasciculations and weakness, weakness, weakness. Then okay, also there will be the effect on the central nervous system, effect on the central nervous system, effect on the nervous system, nervous system. Then what will happen there? Like irritability, 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 unsteadiness, unsteadiness. There will be the acetylcholine exaggerated effect on the nervous system, brain also of this acetylcholine, unsteadiness, ataxia, ataxia, then convulsions, convulsions, tremor, tremor. Even if the patient is not treated promptly and adequately, it will lead to the coma and death. Ultimately death may occur, death. These are the effect on the nervous system. So these are the effect of the organophosphate poisonings, and there will be the other multiple effects also there. And death is also I will mention here. Death mainly occur due to respiratory failure. Death occurs mainly due to respiratory failure, respiratory failure, respiratory failure. Now these are the effect of the OP poisoning. Now we will moving on to its management. How can we manage these effects? Besides giving antidote, a specific treatment, we have to do some supportive measures. Like at first, management. At first, what we can do or we should do, prevent the or stop the further exposure, stop the further exposure. If there is exposure happening at the time you met, you have to stop the exposure with the drug to the patient, stop the further exposure. Then you have to supply the fresh air, supply fresh air, fresh air. Then wash the wash the skin and mucous, wash the skin and mucous membrane. You have to wash with the wash the skin and mucous membrane with soap and water. Soap and water and gastric lavage. Gastric lavage if needed. What is means this gastric lavage means, if let us suppose ingested patient has ingested the these agents, this organophosphates, then if you met timely and if there is unabsorbed this agent, these phosphates, you have to do, you have to take out the gastric content, so that this will prevent the further absorption through the GI tract, gastric lavage. And then main concern is the respiratory failure. So what you also should do, you should do the maintain patent airway. Is there airway patent or not? So you have to maintain it, maintain patent airway. Airway also give positive pressure air, positive pressure air, that is oxygen, if respiration is failing, in that case what you can do, you can give the positive pressure air also. Then supportive measures, you have to apply. Like what is happening there, involuntary urination, defecation and sweating, that will lead to the dehydration. So you have to do the rehydrate the patient, and there is also the blood pressure is decreasing, so you have to maintain the blood pressure and heart rate also. And there is also the in cardiovascular effect, there will be the also cardiac arrhythmias. So to control that cardiac arrhythmias, the needed drugs should be also given. Supportive measures like maintain blood pressure, fluid loss, that is dehydration, hydration. You have to do hydration for fluid loss, fluid and electrolyte, loss of fluid and electrolyte. And other measures you should apply. Then now there will be the specific antidotes. You have to give the specific antidote now. A specific treatment. In a specific antidote, in all cases of the anticholinesterase poisoning, either it is carbamate, non-carbamate, reversible, irreversible organophosphates or others, you have to give promptly the antidote atropine. You know, it is the anticholinergic drug. To counteract the cholinergic action, you have to give anticholinergic drug. So atropine given promptly in all cases of anticholinesterase poisoning. Anticholinesterase poisoning. What it will do? The here is the its action. It has the some limitation in reversing the um, adverse effect. Like it will do, it will reverse the muscarinic effect only. It will reverse muscarinic effect only, since it can block the muscarinic receptors only for the to prevent the action of the acetylcholine, and no nicotinic actions, no nicotinic adverse effects can be reversed by this atropine, like nicotinic actions on the ganglia, nicotinic actions on the neuromuscular junctions, that would not be reversed by this atropine. And how it is given? Given promptly 2 milligram, given 2 milligram 2 milligram atropine is given every 10 minute, every 10 minute. How long, till how long you should infuse? IV till dryness of, till dryness of mouth, dryness of till dryness of mouth, dryness of, till dryness of mouth, till dryness of mouth or other anticholinergic signs occur. Anticholinergic effects are seen or appear. Till then you have to give this atropine intravenously every 10 minutes at dose 2 milligram in every 10 minutes, and maximum dose for one day you can give it as 200 milligram for a day, not beyond that, because if you give excess this atropine, there will be the its atropinic action, there will be the exaggerated. So, and for maintenance therapy, nearly 1 week according to the need, you can give this atropine, and the action is the blocking the muscarinic receptors, and could not reverse the central nervous system action, because this atropine cannot cross the blood brain barrier, hence central effect and nicotinic effect cannot be reversed by this atropine. Then other supportive to potentiate this atropine action, there is the another drug given is the pralidoxime. Pralidoxime, or you may also call it as the 2-palm. 2-palm means pyridine, 2-pyridine, 2-pyridine aldoxime. Its full name is 2-pyridine aldoxime methyl aldoxime methyl chloride. So this is important in like MCQ or Viva. you might be asked by giving this name in spite of this pralidoxime. So I will be showing this mechanism action of the pralidoxime briefly. How these will to reverse this, what it will do, it will reactivate the enzyme, reactivate the acetylcholine esterase enzyme. So let's suppose this now okay, I will run this again. Okay, rub this to pralidoxime. Next is the pralidoxime to palm. This is molecule like, here is the nitrogen methyl group, this is the benzene like ring, you know the chemistry well, and here will be CH and okay, double bond, and there will be the methyl group. Methyl group, here is the 2 electron remained. So what, and in the acetylcholine esterase enzyme, what is there? Let's suppose this is the acetylcholine esterase enzyme, and here will be two site. One site is the steretic site, steretic site. This site is the site where acetylcholine esterase acetylcholine will interact, and by that interaction acetylcholine esterase, this is acetylcholine esterase, by that interaction this enzyme will break down the acetylcholine into the choline and acetate, acetate, and this enzyme also has the another site called the anionic site, and all the drugs, either it is carbamates or non-carbamates like organophosphates, it will bind at the steretic site, same as like the acetylcholine bind here. Then what will happen is that also if you go in at molecular level, this steretic site is near the, this is the enzyme, and enzyme is the basically protein. So protein is made of the amino acid. So this steretic site is near to the serine, is formed by the serine and histidine, two amino acid, histidine, and this anionic site is near at the glutamate, formed by the glutamate. Then what will happen? Carbamates and organophosphate both will bind here at the steretic site and block the enzyme action. Then in case of the organophosphate, what will happen? This anionic site will be the free, and at that anionic site, this positive charge, here is the anion, so it will be negative charge, and here is the positive nitrogen charge. So it will bind at the, in case of the organophosphate, it will bind at the anionic site of this acetylcholine esterase enzyme by this positive nitrogen atom, and steretic site is the, let's suppose in case of the I will taking here talking about the organophosphate only. This organophosphate at stereotic site will bind covalently. Will bind covalently. Covalent bond is a slight stronger bond than the hydrogen bond. Covalently, it will bind at the stereotic site. Then this anionic site will be bound by this. This is the pralidoxime. Pralidoxime. And again this nitrogen group, this nitrogen atom, it has the two remain electron for bonding. What it will do? It will bind at the phosphate atom of the this organophosphate molecule, and by this binding, this will form, this pralidoxime will form the, here is the phosphate, here is the pralidoxime. It will form pralidoxime or oxime phosphonate complex, and leave the reactivated enzyme. This acetylcholine enzyme, now this covalent bond will break and it will leave the enzyme reactivated. This is the mechanism action of the organophosphate poisoning. So pralidoxime is acting by this mechanism. But remember, these carbamates when bind to the stereotic site of the acetylcholine esterase enzyme, the anionic site will not be the free. So if you give this pralidoxime and here is the no free anionic site, it cannot bind at the anionic site, and hence it cannot form the complex like oxime carbamate complex will not be formed, and the enzyme cannot be reactivated. So this pralidoxime, in case of the carbamate poisoning, even contraindicated, because first it cannot bind here and enzymes will not be reactivated. In addition, this pralidoxime, this oxime may have some like some cholinergic effect too of its own. Why? How? So that will be talked in the molecular level, so leave that. But this pralidoxime are contraindicated in case of the carbamate poisoning, because the binding site anionic site is not free for the binding of this pralidoxime. These are the basically the oxime groups molecules. Oxime groups, let's suppose this will include and double bond OH. Same is the here. Okay, here will be the OH group. So remember this. This is the mechanism action of the pralidoxime, and this enzyme also has a limit. This drug also has a limited action. Like if you give after several hours, then due to aging of this enzyme, it cannot again reverse, or this enzyme will not be functional, even also reactivated. Aging means some of the methyl group from this enzyme will be degraded. So this enzyme is not active. And other drugs like obidoxime, in case of the pralidoxime you can give obidoxime, and this obidoxime is even more potent than this pralidoxime, and there is the DAM also, diacetyl monooxime. These are the treatment of this organophosphate poisoning. Hope you enjoy.